Good morning, everyone. I just wanted to say to all of you, welcome. Thank you for making it out on a rainy day. I know some of you have flown in from the East Coast. I know some of you have driven quite a while. And I know one of our speakers hopefully made it in. He was flying in from Vancouver. This conference has been, the planning of it has really been a work of passion, love, and gratefulness for both Katy and I. We met 6 years ago when Katy was just finishing her treatment and I was just starting. And we met through an online, one of the groups, because neither of us could find anybody else that would respond to someone who had stomach cancer. So the moment that Katy and I met, we kind of clicked and we sort of knew that we were going to be each other's support group. She helped me through a very tough time, and I hope I helped her through a difficult time. And here we are still helping each other. And that was the impetus for actually starting the support groups. And so My Gut Feeling came about because we really felt a need that in Canada there was nothing for people that were suffering from stomach cancer, either at early diagnosis or through their journey or even post their journey. And there was also nothing for survivors or caregivers. A little bit about myself. I was diagnosed in 2011, a week before my 45th birthday, with stage 2B stomach cancer. That was my second cancer diagnosis. I had bladder cancer about 10 years prior. The stomach cancer diagnosis was pretty much changed my life. It stopped my life for a long time, and it became my full-time job, as I'm sure many of you know. But I had incredible support from my family and my friends, and I had an amazing medical team, some of whom are here, and I thank them, and you'll hear a little bit about them as we go through the program. I also wanted to thank everyone who has joined us virtually. Sorry for a bit of the late start. We hope that you can enjoy it with us. We are live streaming, so anyone around the world can actually join us virtually. So today is about opening dialogue, learning from each other, and raising awareness about this disease that gets very little awareness and very little funding. So I just want to now introduce my partner in crime, I guess, Katy.
Hi, guys. Just to echo on what Teresa has been saying, thank you all for showing up on a Saturday at 8 in the morning. My gosh. We're really happy to have you, and to everyone watching live, thank you so much for joining us live as well. I mean, Teresa's kind of stolen what I was going to say a little bit, but that's okay. So just a little bit about me. So I was diagnosed with stomach cancer when I was only 21 years old. It was around exam time, and I was a pre-med student, so school was my entire life. I actually ended up passing out, fainting during one of my exams. Never wanted to go to the hospital, never had any health issues before that, and it was just very, very sudden. Stomach cancer, at the time, it took my identity away. As a pre-med student, school was my life, and having to drop out, that really, really destroyed me. And as you guys can imagine, when your identity is taken away from you, you become sad. You become sad and you want to reach out. So I went all over the web looking for some kind of support network for stomach cancer, and there was just nothing out there. So for me to have my identity stolen, although I had a wonderful support system from my friends, my family members, I needed someone to understand what it was like to have stomach cancer. So essentially, My Gut Feeling, as Teresa alluded to, it's just something that's been a long time coming. It was a way of me needing support. It was a way of Teresa needing support. And now we're able to offer support to anyone else diagnosed. So again, a big thank you to everyone who's joining us. We're going to be hearing a lot of personal stories from our survivors, patients, and caregivers. We're also going to be hearing a lot from the medical community. And we're just so proud to offer that combination of medical speakers and patient speakers together in one room to open that dialogue. So thank you very much for coming.
So our first speaker, our keynote speaker, is Dr. Christine Brezden-Masley. I met Christine in October of 2011. I was referred to her by my surgeon at St. Mike's. And the first thing she said to me was, "You're going to be okay." And I was like looking at her thinking, how can she possibly know this? I'm stage 2, this is my second cancer. Anyway, but she had this way about her. She has this way about her. And for any of you who know Christine, she is one of the most caring doctors. She's very patient-centric. She's one of our champions. She actually told me that I needed to do something, that would be how I would get through my journey and my incredible anxiety that I went through, which we'll also talk about later. So in a big way, Christine has been absolutely fundamental in us starting this. For those of you that don't know Christine, she's a medical oncologist and the division head of hematology and oncology at St. Michael's Hospital here in Toronto. And she's the head of the oncology clinical research group there as well. She obtained her PhD in medical biophysics at Princess Margaret Hospital in Toronto and her medical degree from the University of Toronto. Boy, she's done a lot beyond this, because I'm just looking at everything. Anyway, I just want to introduce Christine, and I actually want to give her a big thank you, because she's kind of been there through the last 5-6 years of my life and has always been an incredible pillar of strength for me. So, Dr. Christine Brezden-Masley.
Good morning, everyone. Wow, this is fantastic. I think, as you've heard from Katy and Teresa, that this has been a long time coming. You know, we treat a lot of patients here at St. Mike's with gastric cancer. Something when I was a medical student and a medical resident, I think I saw maybe 2 gastric cancer patients through my whole training, and I went through phenomenal training here at University of Toronto. It's not a common diagnosis, and I think because it's not a common diagnosis, there is a big lack of awareness, there's a lack of support, there's a lack of knowledge, but that is changing. That is truly changing, and it's changing because of patients, it's changing because of you, it's changing because of surgeons, geneticists, psychiatrists, oncologists, clinical trials, understanding what a cancer cell does, understanding how it works, and specifically how this occurs in gastric cancer. So today, I'm going to talk about introducing the whole story of gastric cancer. And I'd like to really thank Teresa and Katy for organizing this. I'd like to thank all of you for coming this morning to support this first inaugural Awareness Day. So we know that cancer is significant. Worldwide, we already have a cancer or World Cancer Day, which is February 4th of every year. And we know that it is a truly global problem. Globally, there are going to be over 14 million patients diagnosed with cancer generally, and in Canada, 1 in 2 will be diagnosed with some form of cancer. And 1 in 4 will die of this disease. So how can we make this improvement? This has actually changed over the last 2 years even. It used to be, 1 in 4 patients would be diagnosed with cancer. Now it's 1 in 2. So as people are living older and living longer, cancer has now become probably the lead in terms of diagnoses and the cause of death. When we look at gastric cancer, today really we want to talk about stomach cancer. That's the whole day. How common is it? What does this diagnosis of gastric cancer mean? And what is happening in 2017? What is happening today? We talk about prevention. You hear a little bit about that. Treatment, we're going to spend a few sessions talking about the advances in surgery that have now occurred, very different than 10 years ago. And there are some leaders here today that will talk about how they're leading that change. And then what I do, I'm a chemotherapy doctor. By understanding how a cancer cell, how a gastric cancer cell works, we can now target specifically those types of tumors. Are we there yet? We're somewhat there yet. We still have a long way to go. But understanding the biology, the molecular biology, and the targets in a gastric cancer cell, that is what we are looking at treating. And the big buzz of immunotherapy, this actually is happening in gastric cancer. Gastric cancer is a target for immunotherapy. Not all gastric cancers will respond, but now we're understanding which gastric cancers will respond. We're going to spend some time about supportive care. It's going to be important to talk about nutrition. The curative treatment for cancer in general is typically surgery. And the stomach is very important in nutrition. So either the whole stomach is removed or part of the stomach is removed. And so it has a huge impact on a person's nutrition. I'll touch briefly about iron supplementation, which is a significant issue in this patient population with patients with stomach cancer, and how we're moving that forward. And then we'll end off with future research. So how common is gastric cancer? Well, gastric cancer actually is quite common globally. It's really, really common in Asia. It leads up to having about 1 million diagnoses of gastric cancer per year. When we look at Canada, the estimated gastric cancer incidence, so the new diagnoses of gastric cancer, is going to be about 3,500. That is the same number as last year in 2016. When we talk about dying of gastric cancer, this is a huge number, 723,000. So if 1 million people are diagnosed per year and 723,000 die of this disease, that's like a 70% mortality. That's huge. We have to start shrinking that number. We have to start diagnosing gastric cancer earlier if that's possible. The difficulty is some forms of gastric cancer are hidden. And so patients will suffer with reflux or some symptom, and it goes undiagnosed for a while until it becomes advanced. So we do have to do better with this number. Now, 3,500 new diagnoses of gastric cancer in Canada, and the death rate is about 2,100. This has gone up 70 from last year. It was 2,030 in 2016, and it's 2,100 now in Canada. How does it look across Canada? Where does this happen? Well, Ontario has the biggest population, so Ontario has the biggest incidence of gastric cancer. And that's probably we see that at most of the centers here in Toronto and Ontario. The second most prevalent and province that has the highest number is Quebec, and then third is British Columbia. As I said, Asia is the leader in diagnosing gastric cancer. And because it's the leader, it's come a long way in terms of improving survival for patients with gastric cancer. The surgical expertise in Asia is phenomenal, and the treatment has also significantly improved. So if you take a look, the blue here is men diagnosed with gastric cancer, and the red are women diagnosed with gastric cancer. So right away you're seeing more men are being diagnosed with gastric cancer. The average age is about 65 years of age, more prevalent in men than in women. And here you can see Japan and China being the most common areas of the world where gastric cancer is diagnosed. The question is why? It could be dietary, environmental, and there could be some biology there. The former Soviet Union, Eastern Europe, there's also a very high incidence there. And then South America, specifically Brazil, has a pocket where there's a high incidence of gastric cancer. When we take a look at Canada or North America, you can see it's further down. In fact, gastric cancer itself is decreasing over time. So gastric cancer is decreasing over time, but the junction from the esophagus, the feeding tube, into the stomach, that area, the gastroesophageal junction, or known as GEJ for short, the GEJ, that actually is increasing. It's slowly increasing with time, and that's probably because of increase of alcohol, increased obesity, abdominal obesity, and reflux. So these are kind of the risk factors. How does gastric cancer occur? So there are some risk factors, right? Sometimes it can be driven by an infection known as H. pylori. You probably have heard about this. That's why we try to eradicate or treat H. pylori infections. As you heard, dietary, environmental, and of course genetic factors. And today you're going to hear from Melyssa Aronson, who's going to talk to you about the genetics of gastric cancer. And so things happen. DNA damage happens with time, right? With cancer in general, age is the biggest risk factor of developing a cancer. That's because as we're sitting here, our DNA is mutating all the time. But our body's able to fix those DNA mutations. As we get older, that ability decreases with time. And so age is always the biggest risk factor for developing cancer. But that's what happens. You have a normal stomach, some genetic modification happens, some DNA damage that's not properly fixed that starts growing. So something switches on, and that's how a cancer cell develops. The most common are these glandular cancers known as adenocarcinoma. And those are predominantly the ones that we see and treat. As you can see, in terms of the treatment options, surgery is predominantly the curative approach. Then we have chemotherapy, biologics, radiation, and that's the targeted treatment is the biologics. So you'll hear more of this. It's just a small cartoon. Once again, when you've got kind of the normal gut lining of your stomach, and then how you can see how it changes when you have all of these mutations that occur, right? So there's all of these things that are happening at the cellular level. And we're going to hear about those today and how that propagates and leads into the development of gastric cancer. By understanding which genes mutate, if they're actionable mutations, can we then target them with some form of a drug? And that is now where we are today. We're trying to understand which targets we can actually hit with medicine. And can we selectively then treat patients, even with advanced disease, even with metastatic disease? That is when the cancer moves outside of the stomach and spreads to other organs. So even in metastatic disease, can we prolong survival in our patients by understanding that cancer? And so this was about 3 years ago in Nature. This was the whole Cancer Genome Atlas. And this is the stomach. And we've understood a little bit in terms of 4 different molecular subtypes of stomach cancer. Why is this important? Well, once again, by understanding if it's developed by a virus, Epstein-Barr virus, whether or not there's deficiency in these big proteins that repair DNA, known as MSI or microsatellite instability. This occurs in about 30% of all stomach cancers. Why is that important? Well, because this can be a target for immunotherapy. This could be a target for the latest breakthrough in cancer therapy, whereby we try to harvest the immune system to help attack cancer cells. The remainder, just called genomic stability and chromosomal instability. And those make up the remainder of the types of gastric cancer. And by understanding that intracellular molecular picture is that we can try then to target. So we now, across Canada, we work in these multidisciplinary cancer clinics. We also have something known as multidisciplinary cancer conferences, whereby you have a surgeon, you have an oncologist, you have a radiation oncologist, a pathologist, a radiologist, you have a whole team sitting there talking about the patient, talking about the type of cancer, and really looking at the best therapy for that patient. So I don't work alone. I work with a whole team of individuals. That's at the kind of medical part. But then in the clinic, we work with a whole other team. We work with dietitians, social workers, psychiatry, palliative care, nurses. So we are all treating at a multidisciplinary approach to our patients. So we need to work closely with the surgeons. The issue, and you're going to hear, is that gastric cancer surgery is a little bit different because of where it sits in the body. So some surgeons, some thoracic surgeons will treat it if it's sitting a little higher up in the chest, and some general surgeons will also treat. So it's a little bit of, it depends on where the patient presents and what type of surgery that they're going to be, or which surgeon they're going to be seeing. I think what you're going to hear also today is that we actually have to standardize surgery in gastric cancer. We have to ensure that our patients are having the best surgical treatment. We've learned from our Asian colleagues that we really need to remove the significant amount of lymph nodes, which are the little glands that sit around the stomach. We have lymph nodes all over our body. When you have a sore throat, your lymph nodes in your neck swell up. This is the first site where cancer tends to move outside the organ where it's originated. So for gastric cancer, we really need to clear out those perigastric lymph nodes. So you're going to hear about how we're moving ahead and ensuring that the surgical expertise is there for these patients. And then really standardizing therapies for our patients. Most recently, we used to treat one type, we used to have evidence for one type of a triplet cocktail of chemotherapy. And over the last 6 months, new data has come forward, really changing how we treat and cure gastric cancer. So now we've shifted our chemotherapy regimen because it's better. So as you can see that there are clinical trials, there's clinical research ongoing, and that we are certainly improving how we deliver care to these patients. The question always is, do we need to give radiation preoperatively? So we're giving now a lot of chemotherapy in the curative setting, pre-surgery to debulk. That's been a big shift in gastric cancer, that we try to shrink down the tumors, improve the surgical kind of clearance of the tumor and the lymph nodes, and then we tend to give more chemo afterwards. So the question arises, do we need radiation? And I was just talking to Dr. Natalie Coburn about this trial. It's open at Sunnybrook and it's open at Princess Margaret. It's called the Top Gear. This is an Australian-Canadian initiative, and it's asking the question about radiation therapy and whether or not it would improve outcomes pre-surgery. Now, what happens when gastric cancer becomes incurable? What happens when it becomes metastatic? What we do know about gastric cancer is that it does have a high recurrence. So it does come back. That's why when you have 1 million diagnoses and 726,000 deaths from this, we know that this gastric cancer can come back. So how can we minimize that? How can we improve that? So even though it has a very high recurrence, we are now, as I said, understanding how that cancer cell works. The recurrence tends to occur in the first 2 to 3 years. That's why we watch our patients very closely in those first 2 to 3 years. When you're out of that kind of danger window of the first 2 years, after 4 or 5 years, we discharge patients. I discharge patients after 5 years. Gastric cancer most likely is not going to ever come back. However, patients need to be monitored and have obviously healthy lifestyles and have healthy diets. So if it does come back, well, we have heard that there's evidence that when it does come back, you'll hear, well, can you just take the stomach out? Like, the cancer's there, I know it's spread elsewhere, but can you just take the stomach out? This was an Asian trial that was called the Regatta trial that showed, I have a picture of Dr. Grantroff, who's one of our surgeons. He's not part of the Regatta trial, but there's a nice picture of him. That surgery really is not beneficial in patients when stomach cancer spreads to other organs. In fact, if you think about it, removing the stomach, now there's some cases where we might want to bypass so we can improve the nutrition of patients, but removing the stomach will delay the chemotherapy or delay the therapy for patients. And also, this is a big surgery. So some patients never really recover from a big surgery. And so by removing the stomach, I think now we're just focused on ensuring that we have really good therapies for our patients. So there have been multiple clinical trials. The clinical trials whereby we are experimenting and we're trying to improve the therapy for our patients. We're pushing that envelope in terms of newer therapies. And this is just a very simple cartoon of those. So if you can imagine that this is a cancer cell, and within this purple blob in the center, that's a nucleus, that's the powerhouse, that's the engine of a cell. This is a very simple diagram of pathways within the cell. From the cell surface, which is the top, you see all those little receptors on the cell surface. We're trying to understand what makes that cancer cell divide, right? That's why we give chemotherapy, to stop the division of those cancer cells and kill them. But now we're understanding that cancer cells are smart, right? They have these mutations, they have these targets, and so as I said earlier, we're trying to really target these mutations or these on switches that makes that cell divide and become quite aggressive. And so there have been lots of antibodies and targeted medication that ensures that we were trying to understand how to stop that cancer cell. And we kind of really look, there's three main ones that have been beneficial in gastric cancer. So these are the molecular targets that we're currently using today to treat advanced metastatic gastric cancer. So there have been multiple clinical trials, and I'll show you a graph in a minute that shows that there's a lot of research now that's happening in gastric cancer. Gastric cancer used to be kind of an orphan disease 15 years ago, 20 years ago. There wasn't much happening. Now, by understanding gastric cancer, by understanding the mutations in gastric cancer, we're now able to run more clinical trials and test these new compounds. So these are the clinical trials over the last 20 years. As you can see, in 1997, not much really was happening, right? In terms of publications, this is from PubMed, that over the last 20 years, you've seen over like 160. So really there has been a huge growth, huge body of knowledge that we're gaining from these clinical trials, and also within publications. So there's the knowledge translation piece is now out there. And we, hopefully this will continue to increase over time. So you're going to hear today from Denise Gabrielson about nutrition. Nutrition is very important. Right? How can we get our gastric cancer patients to eat properly, specifically if they've lost their stomach or part of their stomach? And then, as I mentioned, we've done quite a bit of work here at St. Mike's looking at iron deficiency. And the problem is that this usually gets, and we've been guilty of this, we don't really look for iron deficiency. Patients come in anemic, their tumors have been bleeding, especially gut tumors bleed, and that's usually a trigger to start looking for if there's something that's causing the bleed, right? So as you bleed, you lose blood and you lose iron. On top of that, iron is absorbed just outside of the stomach, called the duodenum. And when patients have surgery, that part is removed. And so think about it. Patients can't absorb oral iron. So if you're given a pill to take and try to absorb iron, it's not going to happen really. So that's why we have to give more intravenous iron to our patients. That has to be diagnosed and that has to be treated. We'd be surprised how well patients do when that iron is actually repleted. And overall, this does improve the quality and quantity of life of our patients. So today we're going to hear about how tumors arise, how can we prevent them? You're gonna hear about the better surgeries. You're gonna hear about better treatments. I just saw Dr. Howie Lim come from Vancouver. He's gonna be talking to you about what Vancouver is doing in terms of understanding the targets and how you can actually the actionable targets and how to target them with certain medications. And we're going to hear about the better supportive therapies. So nutrition, I believe we talked about iron. We're going to hear about Dr. Kian Dang from psychiatry to talk about the psychosocial aspects of gastric cancer and cancer in general, about exercise and well-being, and there's always, as I said, the big team includes palliative care or supportive care. So to finish off in my last minute, gastric cancer in 2017, there have been significant improvements over the last 20 years, specifically over the last 5 to 10 years as we're understanding how these tumors behave. Positive change is coming. We still have a ways to go. And you know, the whole point is that we are all working together. And I think that is the strength of oncology in general, is that multidisciplinary teams are working together to improve research, to improve treatment, to educate our patients, educate each other, and provide support. I said periwinkle blue is the color of gastric cancer, and really we need to empower you. We need to empower patients and caregivers. So November, we have a few days left. We had Black Friday yesterday. Hopefully you all went shopping. November is Stomach Cancer Month. As I mentioned, periwinkle blue is the color. It's a beautiful color for gastric cancer. And next Thursday is going to be Stomach Cancer Awareness Day, and I think you'll hear more about that today, is that the CN Tower will be periwinkle blue, and there's going to be lots of parts in Toronto that will be periwinkleized. So thank you. I'd like to dedicate this to all the gastric cancer patients. Thanks. Does anybody have questions? That's okay. There's going to be lots of great talks to have questions for. Thanks.
Thank you so much, Dr. Brezden. As Teresa mentioned, we honestly could not have done My Gut Feeling and have had all you wonderful people here without the help of Dr. Brezden and all her support and the support of St. Michael's Hospital. So thank you very much. That was an excellent overview. I know we probably have a little bit of questions, but we're a little bit shy right now, and that's okay. Just so you guys know, we will have a panel discussion, so write down those questions. You all have notepads in your bags, and then we will discuss all of them. We will get to all of them. So the next person I would like to introduce is actually just sitting right there. His name is Jan. So Jan was diagnosed with stage 3B stomach cancer back in 2015, and he was only 35 years old. Now, what I wanted to tell you guys about Jan, actually, he is our all-star member. He was there at the very, very first support group that we ran for My Gut Feeling. I remember Jan came in all shy and timid. He walked in, introduced himself. Teresa and I, we were biting our nails because, you know, we were like, oh my gosh, is anyone going to show up to this very first support group? And there was Jan. Since Jan has joined us, it's been 1.5 years, and he's come to almost every support group that we've had. He went from the shy, timid person to, like I said, one of our all-stars. He currently mentors a lot of our members at My Gut Feeling. And honestly, I can't say enough good things about Jan. So without further ado, Jan.
Wow. Thank you to My Gut Feeling, especially Katy and Teresa, for letting me speak here today at the first annual conference dedicated to stomach cancer. Before I jump in, I just want to say that I am comfortable, well, What does that mean? I am feeling a little bit of the jitters up here, don't get me wrong, but I am comfortable. Comfortable knowing that each and every one of you here today in this room understands and knows what this is all about. I don't need to say much, but I will. This is a place where we share our fights, battles, journeys, whatever you want to call it. A place where medical professionals can share information and push the battle forward in areas of oncology, surgery, genetics, and psychiatry. We are all on the same wavelength, really, and that indeed makes me feel comfortable. Looking back, I would think the physical symptoms of this disease started a few days after I ran a 10K marathon for a fundraiser, funny enough. At that time, actually for a few years, I was hitting the gym constantly, gave up smoking, even though I wasn't a heavy smoker, watching what I was eating and doing all the good things that you were supposed to do. This was about in May 2014. It started with an annoying cough that just wouldn't go away, and it ran into the summer, so it got pretty annoying. I went to a few doctors, and I was told that it was acid reflux. So I was prescribed prescriptions like protein pump inhibitors, which has made news recently of actually doubling the risk of developing stomach cancer. So the coughing did go away, and I was okay for a while. Traveled to LA for a bit with my family, thought my health was cool, and that was great. But as winter came, the coughing came back, and the next thing you know, I was back on the medication, the PPIs to control the cough. So about late 2014 is when I really started to feel the fatigue. I would get back home, and it just immediately just crashed out. I thought maybe it was from overworking or maybe not getting enough sleep. I remember my wife telling me, oh, you should go sleep early, and she was mad at that, and so I tried to follow that. But I did feel that something was off, though. Thinking about it now, perhaps I should have, listened to my body back then. But, I just played along, I just did what I normally do when I get sick, is just ride the course, really. But at that particular moment of my life, a lot of the attention was given to my wife. She was pregnant at the time and was ready to give birth. And so at the end of January 29th, we gave birth to our baby boy, Colton. So we had one boy, one girl. We're done. That's it. And yeah, so with Colton in the family, everyone's attention was on him, especially mine on both our kids. I wanted to make sure our girl was still our princess and our secret number one. But as time moved on, it was March, and then I still felt unwell. I went back to the doctor and told him that, whatever you were prescribing wasn't helping. I was still feeling quite ill. At this time, I was really fatigued. I lost a lot of weight, and I felt cold all the time. I would, ask people at work and tell them, like, how cold do I feel? They're like, wow, you feel really cold. And the doctor sent me off to do blood work. And immediately, that's when the alarms went off. I was immediately referred to Dr. Kolbasnik in Oakville for a colonoscopy. I truly wasn't expecting much, really. I thought maybe it was like an ulcer or something else that wasn't so serious. But man, I remember after the surgery, groggy lying in bed, and with my wife beside me. Dr. Kolbasnik emerges from the curtains and comes up close to me, and he whispers, from his words, oh, I'm sorry, we found something, we found cancer. And I said, oh, are you sure? And he responded, oh, I'm sure, I'm really sorry. And we cried. And I remember my wife holding me really hard, and we cried some more. And then, a few minutes later, the doctor heads over to the patient beside me, and I overheard his prognosis. And then he says, polyps. I said, that son of a bitch, lucky him, because, I wish I had the polyps, that would be fine by me. So, telling your mother and father wasn't a hoot. I was 35, pretty young, and I don't think they expected that type of news. I remember my mother running out the door, out of the house. I think she went straight to church, if I remember. And I don't think I even told my daughter straight up, officially. I think she just figured it on her own, like with multiple hospital visits. She just connected the two together, and she just found out on her own, really. But early in that time of my prognosis, it was like Christmas every day. There was a lot of people to come around to help, came with me to hospital visits, bring my family food. You know, they made me those iron-rich, healthy diets, foods, because they knew I had low iron. And, but it's funny, in that time, you kind of know and figure out who your true friends and family are, because a lot of people went missing. And then you saved a lot of money with a shortened Christmas list, so that was okay too. Although Dr. Kolbasnik was the bearer of bad news, he was amazing in those early times. He got us immediately connected to Dr. Darling and her wonderful team there at Princess Margaret. They had that positive mindset that I really needed that much, you know, at that time. After initial tests, you know, they determined the staging, 3B, and they determined I wasn't eligible for surgery right away as it touched several lymph nodes. It was a little setback, but my oncologist and the one leading my chemotherapy treatments, Dr. Chen, you know, he assured me with a solid plan and needed to execute that to be where I needed to get to be, at least. But it was surreal, though, going into the chemotherapy unit for the first time. You walk around, see people of all ages sitting in quite comfy chairs, and they're attached to all these machines, and with all these bags just hanging around them. Yet here they are, sitting with smiles on their faces, joking around with their friends and family, grabbing a snack, sleeping, and I really couldn't believe I was there. But eventually I got settled in and became one of the regulars as well, and I too got to know the staff. Actually, on my first day there, as life-changing as it already was, it became more special when I had the privilege of meeting one of the people who made an impact on my life within a short period of time. I met a man named Jerry and his family. He could sense I was new there, and he, you know, he's the general there. He knew everybody and on a first-name basis, and he probably saw me, you know, a deer in headlights, and he knew I needed some help. He gave me some tips on dealing with nausea, recommended me to use coconut oil on my body to keep those skin effects at bay. You know, he gave me the 101, really. We became buddies, and luckily our families became close over time as well. Although he's not here today, you know, his spirit does live on. I just wanted to mention him because there are people you come across in this lifetime and just bam, just have this immediate impact. And he was one of them. He carried the same kind of ethos as everyone else here today. He was sharing of information, he was loving, took care of his family. We did meet under, you know, unfortunate circumstances, but I'm sure, you know, really glad to have met a fine gentleman like him. After several rounds of chemo, that consisted of capecitabine, Herceptin, anti-HER2, the playbook that Dr. Chen drew out for me was executed successfully, and you know, there were some positive results. I was grateful to be put in a position where, wow, I'm actually eligible for surgery. So in November of 2015, I headed into Toronto General Hospital, where Dr. Darling and her team performed an 8-hour surgery where they did a total gastrectomy and removed those touched lymph nodes. And luckily, when they've looked at them, they said that they were clear as well, which was also good news. I remember being in a dreamlike state, you know, lying on the bed after surgery, and Dr. Darling approached me. I remember her smile and, you know, her whisper, a good whisper at a time, and she was saying, "Oh, we got it all, we got it all." And I remember just being happy, smiled, and I just laid back and crashed and fell asleep. Hearing that, though, was important to me, because right after my surgery, I was sent to the intensive care unit, where patients like me, you know, who stayed there for a long time, some short-term as well. But in that time I was there, I would see patients and hear patients that went through the same thing, and they just weren't as successful like I was. And I heard patient prognosis, anger, pain, crying. I only wished, the best for everyone in that room. But being in that room, that was definitely appreciative, grateful, sad, and sometimes felt a little bit of guilt, to be honest. I was there for a few weeks for recovery, but then I was back at the hospital again for a blood infection where I spent happily spent Christmas with my family there. That wasn't a problem. Come spring, I was back in full force and ready for more chemo. I was a little bit wary though. I mean, how is my body going to react to it? Was I strong enough? How severe would the reactions going to be? But luckily, with those rounds of chemo, I was okay. I was blessed. I mean, at times I did feel some nausea, a little bit of sensitivity, tingling in the fingers, but nothing serious. Maybe it was from those tips that Jerry gave me, being in the hospital the first time for chemo, but, he's probably just watching me from above. I was blessed for sure. But in April of 2016, I finally received the official document stating that I was clear with no occurrences of the disease. This is something that we all imagined and wished for, wished the universe for, really. And, there was no doubt in my mind that we'd reach this goal, but, it's tough. You gotta have that positive mindset, as everyone says. And that's all we've done since we've, heard the whispered words of that bad prognosis from the doctor. So the road to recovery, or the new normalcy, will always be, at least I think at this particular point in my life, and I'm fine with that. I take it as a day by day or meal by meal, as I always have. Eating and diet is a continued challenge. I think a lot of you may know that. But I've certainly found a brand new heightened appreciation for food, for sure. I don't think I have any restrictions except maybe really creamy ice cream, which I stay away from. But, I enjoy spicy food. And actually, for me, the spicier the better. It works for me. I don't know why, I don't know how, but I'll gladly take that so I can still continue eating some curries. I don't mind that. And most importantly, I can still enjoy a nice cup of coffee, an Americano, and I can still eat sushi, which is really important to me. With that said, though, I stand in front of you in good health. I'm trying my best, to play out the hand that I was dealt with. But I'm definitely not alone. I mean, look at everyone here. And with platforms and supportive groups like MyGutFeeling, it gives us an opportunity to share our tips, experiences, and growth, to keep us all moving forward. And before I go, I just wanted to thank my lovely wife, my rock, again, for being there for me. I mean, Nicole, I couldn't have done it without you. And you know what? She was also most importantly, my internet filter. I stayed away from the internet. Being on there it can be toxic when you're diagnosed with something like this, and she did that for me. I think that helped me extremely mentally and got me to where I am today. So I thank you, humbly thank you. Thank you very much.
So now you know why we call him one of our superstars. Jan has always had such an incredibly positive attitude to anything that he's had to face. And he and I always kind of go at it, because I can't eat spicy food, so I get really, really upset that he can. But that's kind of the struggles that those of us with this disease have. Some of us, it's always very individual. So our next presenter is Melyssa Aronson. And Melyssa has been a genetic counselor at the Zane Cohen Center for the Digestive Diseases since 1998, and she's the senior genetic counselor since 2000. The center provides clinical counseling and testing for individuals suspected of having a hereditary GI cancer syndrome and runs the research registry. I met Melyssa in November of 2011. It was the whole journey, because I was told when I was diagnosed that, wow, you've been hit with cancer twice. Have you ever considered getting genetic counseling or testing? And I was like, well, no. And although cancer is very prevalent in my family, it had just never come up. No one had ever talked about it. But I had been hit at 35 and then at 45. And so I went with my husband and met with Melyssa, who actually focuses on gastric cancer. She's the only one. So we're really appreciative of the work that she does. And we had, I think, a 2.5-hour session going over my family tree, and she was incredible. And the things that she opened my eyes to were amazing. So I would just like to introduce Melyssa Aronson.
Right there. Yes, thank you, Teresa, and thank you, Katy, and thanks for the invitation. It's amazing what you guys have accomplished. Really, congratulations on this day. It's incredibly exciting, and it's really important to have get-togethers like this so that we could talk about the advancements of stomach cancer. I'm just going to see if I could, oh, there we go. Okay, so I'm going to talk to you today about hereditary stomach cancer syndromes. And as Teresa mentioned, I work at Mount Sinai Hospital in the Zane Cohen Center, and I specialize in hereditary stomach cancer. And so I'm really excited to be here today to present this to you. So I thought I would focus on 4 families that have 4 different hereditary syndromes, just to give you an idea of the variety of families that we could see. I'll try and go over some of the features that prompt us to think about what might be a hereditary syndrome. I'm going to focus a little bit on one syndrome called hereditary diffuse gastric cancer syndrome, and I'll talk to you a bit about how genetic testing works. So the first point I'll make is that all cancer is genetic, but not all cancer is hereditary. And I'm going to spend a second on this because it's a really important concept for everyone to understand. If we think about our cells, at birth, our cells look normal for most people. And eventually, as you age and over time and through exposures, your cell may acquire a genetic mutation. And if it happens in one of the genes that control the cell's growth, how often it should divide or when it should stop dividing, then the cell loses the ability to control its growth and it starts to grow out of control. And that's what cancer is. It's our normal cells growing out of control. So if that cell with a mutation acquires more mutations, eventually it will lead to cancer. And so all cancer cells will have genetic mutations. That's a little different than a hereditary syndrome, where these people are born with a genetic mutation in every cell of their body from birth. They were born with a genetic mutation. And that, if one of those cells go down the pathway where it acquires more mutations, it too will turn into cancer. So these people are predisposed or more susceptible to developing cancer because they already have the first hit from birth. And if you look at the cancer cells, both cancer cells, whether it's hereditary or not hereditary, have genetic mutations. But if you have to look back at the original cells, which we usually use blood cells to do that, to see was this person born with a genetic mutation, or were they born with no genetic mutation and this acquired over time? This picture you've already seen from Dr. Breslin, so you could appreciate it's probably an important paper that we all read. And this paper showed the genetic changes that could happen in all stomach cancer. And so it shows that there are genetic mutations in all stomach cancer, and it's important for us to learn that. But only 10% of stomach cancer is hereditary. So 90% of people who have stomach cancer do not have a hereditary predisposition to it. And I'm going to focus on the 10% that have a hereditary syndrome. So this is a busy slide, so it's just showing that I have 4 families I'm going to show you, and we'll go one by one through them to talk about the genetic conditions. So here's the first family tree. This is how we draw it in genetics. Circles are representing women, and squares represent men. If you're joined on top, it means your brother and sister, and if you're joined in the middle, it means your husband and wife or partners. So here's someone who had stomach cancer at 43 years old, whose mother had colon and uterine, or cancer of the womb, endometrial cancer, whose uncle had colon cancer at 49. And this is a genetic condition called Lynch syndrome. Lynch syndrome predisposes mostly to colorectal and uterine cancer, but it does increase the risk for stomach cancer, among many other cancers like ovarian and other cancers of the digestive tract. And just to give you some idea, if you have Lynch syndrome, your risk to develop colon and endometrial cancer may go up as high as 70% risk over your lifetime, which is quite high. Your risk for stomach cancer, though, is about a 1 to 10% risk over your lifetime. So we don't see as much stomach cancer in our Lynch syndrome families, but the cancer risk is much higher than the general population, so it's more common in our families with Lynch syndrome. And Lynch syndrome is an important syndrome because almost everybody who develops cancer in Lynch syndrome will have that feature that we recognize as maybe being important for immunotherapy. So if you have a cancer related to Lynch syndrome, there are studies showing you may respond better to immunotherapy. So not all stomach cancers will respond to immunotherapy, but people with Lynch syndrome stomach cancer may be the ones that do. So here's family number 2. Family number 2, this person presented with breast cancer at 42 years old and stomach cancer at 49 years old. And they had a sister with breast cancer, and they have a son who had some colon polyps. So these are little benign growths in the colon that can grow that could lead to cancer eventually. And these polyps, in the colon, they have these long stalks, and we call them hamartomas. So this is another example of someone who has a hereditary syndrome that causes stomach cancer, and this syndrome is called Peutz-Jeghers syndrome. The other interesting thing about someone in a Peutz-Jeghers syndrome family is that they may have this unusual freckling inside their mouth or on their fingers or on their toes. So it's not just the cancer that we look for, it's also the colon polyps, and it's also other skin features like these abnormal freckling that they get. Now, Peutz-Jeghers patients have a very high risk of developing cancer in their lifetime. It's over 90%, and they have a risk of developing lots of different types of cancer. And you could see the stomach cancer risk is about 29%. So it's quite high if you have this genetic condition. But they have a lot of other genetic a lot of other cancer risks, including breast cancer, colorectal cancer. So they may not present to us as a stomach cancer family. They may present as a colon cancer family, or someone with these hamartomas, or someone with freckling in their mouth. And we have to be aware that we're going to have to watch out for stomach cancer in these patients. There are other genetic conditions where people present with polyps in their colon that also have an increased risk for stomach cancer. And I'm just mentioning a few here. There's one called familial adenomatous polyposis, where patients have hundreds and thousands of polyps in their colon, and we recognize them because of that usually, but if you're not aware that they're at risk for stomach cancer, you may not know that you have to watch their stomachs and do screening of their stomach to make sure that they are being watched very carefully. The third family I'm going to show you is hereditary diffuse gastric cancer syndrome. So here's another family, and you can see the difference in this family is there's a lot of stomach or gastric cancer. Stomach cancer at 32, a father with stomach cancer at 49, an aunt with breast and stomach cancer at young ages. So this family is a predominantly stomach cancer hereditary family. And just to give you the difference between this and something like Lynch syndrome, if you have this genetic condition, your risk to develop stomach cancer in your lifetime as a male is about 70%. And if you're female with this genetic condition, it's about 56%. So astronomically high risk of stomach cancer if you're born with this genetic condition. You also have an increased risk of breast cancer if you have this genetic condition, so we also watch for breast cancer risk. And I hope you can appreciate that with these genetic conditions, it's never just stomach cancer. It's often stomach cancer plus other cancers, and that's one of the reasons it's really important to identify the genetic risk, because once you get past the stomach cancer diagnosis, you don't want to miss a colon cancer, which could be easily caught through screening, in fact, before it's even colon cancer, or a breast cancer, which you could catch early with a mammogram and MRI. So if you don't know you're at risk for these other cancers, you might not be getting the right screening, and identifying the genetic risk helps us figure out the right screening protocol outside of the stomach cancer risk for you. So I'm just going to focus on this word diffuse. What does diffuse gastric cancer mean? Well, as you heard already today, most stomach cancer are what we call adenocarcinomas, as opposed to a lymphoma or a sarcoma. Adenocarcinomas arise from the epithelial cells, the cells that line the stomach. And you can further divide adenocarcinomas, subdivide them into this group. So we have intestinal type adenocarcinoma, diffuse type adenocarcinoma, and intermediate mixed type adenocarcinoma. So about 30% of all the adenocarcinoma cancers of the stomach are going to be diffuse type. Diffuse type cancers grow in a really sneaky way. They grow sometimes under the lining of the stomach in a diffuse way, which means kind of a widespread way. And the reason that's so tricky is because you could do a gastroscopy where you look into the stomach and the stomach will look normal on the inside and you're not seeing the cancer growing just out on the outside of the stomach. And so it's a very tricky cancer to screen for because our screening may not be able to detect it. So if someone has this genetic condition and has a 70% risk of getting this type of cancer that we can't find through our screening, what do you do about that? Well, you're kind of caught between a rock and a hard plate. Either you do screening, like this gastroscopy, which is possibly going to miss the cancer, and if you miss the cancer, that's a concern because we may not catch it in time. And for patients with this syndrome, we will screen them every year and do 30 biopsies, random biopsies of their stomach, hoping we might pick the part that might have cancer, but you can imagine we're missing a lot of the stomach if we're only doing 30 biopsies. So you either do that, or you have your entire stomach removed when you're healthy without cancer to avoid the diagnosis of getting stomach cancer. And people think to themselves, that is such an unbelievable thing to think about, that I'm going to have stomach surgery to remove my stomach before I even have cancer. But actually, that's the choice many of our patients with this syndrome make because the risk is so high and we don't know how to screen for it. And we're actually at our center at Mount Sinai, we're a specialty center, so we've been inviting people to donate blood samples and follow families since 1980, so we're a provincial registry. So even if you're not seeing it in our clinic in Toronto, if you're seen outside, we invite people to come to our clinic. And right now we're doing a study of people who've had this surgery, this preventative surgery, to see how they're doing 2 years out, 5 years out, a year out, what's their diet like? Can they eat ice cream? Can they gulp water? They usually cannot, but these are the kind, can they eat spicy food? Can they not? How is their energy level and so forth? So that we could create an education booklet for people trying to make this decision in the future and what kind of things they might have to think about. This one patient who I'm showing you here, who had his stomach removed, after we look at the stomach in pathology, we almost always find microscopic cancer. And he had 9 tumors, actually, this patient that we found. None of them had spread. They were all teeny tiny little tumors. He didn't need any treatment after. And if we would have left his stomach in, he most certainly would have developed diffuse gastric cancer. And his mother had died of diffuse gastric cancer, and he had a little child. So he felt really glad that he made this decision because he probably saved himself from this fate. Hereditary diffuse gastric cancer is a genetic condition, as all the other ones are. This is looking at one cell of the body. If you were to take a blood cell, a skin cell, a stomach cell, any cell, these long strings are what we call chromosomes, and there's about 20,000 little beads along these strings that we call genes. And you're born with 2 copies of every gene, one you get from your mom and one you get from your dad. And you have 2 copies of this little gene here on chromosome 16, which we call CDH1. If you're born with a mutation in 1 copy of your CDH1 gene, you have hereditary diffuse gastric cancer syndrome. It doesn't mean you're going to get gastric cancer, but there's a very high chance that you will, as I said. And this gene controls how the cell looks at its neighbors. So it tells the cell, oh, you have a neighbor right here, don't grow anymore because there's a cell beside you. If this gene doesn't work, all of those boundaries are gone, and the cell doesn't realize it's going to encroach on other cells, so it starts to grow out of control. And that's why this gene, if it's not working properly, will cause cancer. If you have a genetic mutation, there's a 50% chance you'll pass that mutation on to your child. And so your child could inherit this syndrome, and presumably you inherited this from your parent, so there's a 50-50 chance your brothers and sisters will have this mutation. So genetics doesn't just impact you, it impacts you, your future generations, your siblings, their children, and so forth. So it becomes a whole family affair. And actually, as a genetic counselor, I often meet whole families, them, their cousins, their aunts, uncles, brothers, sisters. So I should be invited to all the family reunions after I meet the 50 people in the family. So these are our 4 families. The first one has Lynch syndrome, the second has Peutz-Jeghers, the third has hereditary diffuse gastric cancer. What does this last family have? This one with no family history, but a stomach cancer at 21 years old. This family usually comes back with no mutation identified. Now, how could that be that this 21-year-old doesn't have a hereditary syndrome? How did this 21-year-old develop stomach cancer just through environmental exposure? It seems that we are probably missing something, and that is the case, we think, for the majority of people with hereditary stomach cancer. We can't find the mutation in the majority of our families, and that means that research has to continue to look for new genes in our families so that we can identify the hereditary cause of all of our families so we can help figure out what their risk is and what their family's risks are. This is just a graph showing the people that we've seen at the Zane Cohen Center, and you can see this is by age, so people diagnosed with stomach cancer under 20 years old, under 30 years old, under 40 years old, and most of the people diagnosed under 40, even under 50, do not, the blue represents no genetic mutation. Most don't have a genetic mutation that we've been able to identify. A few have CDH1, a few have Lynch or other syndromes, but most we can't find. And we only find diffuse gastric cancer mutation in about 8 to 12% of our families, which means 80% of our families don't have the highest risk syndrome that we look for. So that means there's a lot more that we need to do, and that it's good to be involved in research so that we could continue to look for new genes. So some of the characteristics of a hereditary stomach cancer family that you should look for in your own family or in loved ones if you know someone with stomach cancer is if they have multiple relatives with stomach cancer or one of the related cancers that I mentioned, colon polyps, breast cancer, colon cancer, and so forth, or if one person themselves have more than one cancer, like bladder and stomach cancer, those are families that we would probably want to look at. There are other cancers, though, in families. So, for example, if you have stomach cancer at 70 and your dad had lung cancer, but he was a smoker, and you had an uncle with prostate cancer at 80, that's not a pattern of a hereditary syndrome. That's probably some environmental factors that cause the lung cancer. Prostate cancer is really common, and the stomach cancer is probably not hereditary. So we look for related cancers together. If someone's diagnosed with an early age of stomach cancer, under age 50 is what we consider early. Even if they have no other family history, we will do genetic testing for them. If you have other findings that I mentioned, like the freckling inside your mouth or on your fingers or on your toes or any polyps or anything unusual like that, we would want to look for hereditary stomach cancer in patients like that. And we do take a look at what type of stomach cancer people have. Do they have diffuse type? Do they have intestinal type? But it's not that one is hereditary and one is not. Not all diffuse type is hereditary. Not all intestinal type cancers are not hereditary. It's 10% overall, but it may help us think about what syndromes we want to target. So if you have an intestinal type cancer, you probably don't have the hereditary diffuse type syndrome. There are other syndromes that I didn't mention today. There are lots. So for example, the hereditary breast ovarian cancer syndrome, sometimes we find mutations in that gene in our family. And so now when people used to come to me 20 years ago, I would test the one gene I was most suspicious of. Now we test a whole panel of genes. So here's gastric cancer. Here's the names of all the different genes that we can test for. And they've highlighted which ones they suggest. This causes FAP. Here's CDH1. These ones are associated with Lynch syndrome. And so now we test a panel of about 20 genes. In 2 years from now, we may test a panel of 50 genes. That's how quickly genetics is growing. And so if you had genetic testing and they found nothing, you should go back to your genetic counselor and say, maybe can you test me again? Because if you saw me 2 years ago, I'm doing totally different things than I'm doing right now. So some of the take-home messages are most stomach cancer is sporadic, meaning not hereditary. But some of the flags for hereditary syndromes are early onset cancer, multiple related relatives with cancers, multiple cancers in the same person. If you recognize any of these features, you should ask your doctor to refer you to a genetic clinic for consultation. And if you're a doctor, you should be referring every single one of these patients to a genetic clinic. We are getting an under-referral of stomach cancer patients, meaning they're not coming to genetics. They're falling through the cracks. And this is a really big concern because the genetic testing has to be done on a blood sample from someone with stomach cancer. So we have a lot of families that come to us who say, my brother had stomach cancer at 30, but he passed away, and now I want to do the testing, and we can't do it for them. We needed to do it on the brother who had stomach cancer. And then they'll say, but he had so much blood taken when he was in the hospital. Can't you use some of that blood? And we cannot, because it wasn't processed in the way we need for genetics. So if we realize that when people are going through the diagnosis, they have so many things on their mind, and they are not in the mood to listen to genetic interpretations. Maybe it's not the right time, but it is possible to take a blood sample and bank it, and then deal with the genetics later, but at least we have a blood sample available if we want to do genetic testing. The type of stomach cancer can influence what syndrome people are at risk for, so that's another take-home message. The most common hereditary stomach cancer syndrome is the hereditary diffuse type gastric cancer, which is caused by CDH1, and it's also associated with breast cancer. So it's also important to keep in mind that these syndromes are not just one cancer, they're often multiple cancers we think about. There are other syndromes, of course, that can explain hereditary stomach cancer. But still, the majority of our high-risk looking families, we can't find the gene mutation, and so lots of research needs to continue. And that's it. Thank you so much. Do you want to do panel? I don't know. Whatever. Sure. Are there any questions? Yep. So, right. So sometimes it's good to refer people like that anyways, because we'll ask a lot more questions that that you might not be thinking of. How big is the family? Do you know everybody's diagnosis? Some people have died at a young age and they don't know why, or they're not in contact with someone, a parent, and so forth. So we do a little bit more intensive questioning if they're pretty close aligned. If your husband was 70 and that was the only one, we may not investigate, but at 52 we'd probably still investigate. And then sometimes we talk to the patient, if they're right at that border, if genetic testing is really important to them, then sometimes we do the genetic testing for them because we feel it's going to make a big difference to them and their attitude and their recovery, just to even sometimes put it to rest that we can't find a genetic cause. Usually you ask your doctor, the oncologist, the surgeon, whoever, to make a referral to a genetic clinic. There's one at Mount Sinai. So we specialize in just stomach and GI cancers, but there are other genetic clinics around Ontario and around Canada that do general genetics, and they also see people with stomach cancer. Sure.
Hi, Melyssa.
Hi.
I think I have two questions. So I went through genetic testing, I guess, 5 years ago. So I'm a Lynch carrier. And so is it time for me to retest?
They already identified that you do have Lynch syndrome?
Yes.
Yeah. So if you already know what your genetic condition is, that explains it. You have your answer, so you don't need to look for any other causes because we know what caused yours. But it may be important to connect just to make sure you're getting all the correct screenings. So in other words, colonoscopies every 1 to 2 years, endometrial screening, and so forth. And then thinking about family members at risk. But once we find the genetic cause, we have found it and solved the mystery in your family. So you personally don't need to do any more genetic testing if we know what the mutation is.
Okay, so you wouldn't test, I saw that huge list of other mutations, so you wouldn't test for other mutations?
Not unless we suspect there's something else going on in the family. So for example, we have some people that come to us with stomach cancer, and then they start presenting with melanoma in 5 relatives, and we didn't look at the hereditary melanoma gene. So then we'll start looking at other genes. But if you have Lynch syndrome and your family history is only colon, endometrial, stomach, the Lynch syndrome genes, and in fact, in Lynch syndrome, you could even look at the tumor to see if it's missing the Lynch syndrome protein, and then you see the direct cause. And sometimes we even do that to say this was definitely because of Lynch syndrome, then we don't need to look at any other, because people don't usually have more than one genetic disease. They're all very rare. So if we found the one for you, then that's probably the only one you've got.
Okay, great. Thank you.
Yeah, you're welcome. Great. Thanks.
Thank you so much, Melyssa. This one? Oh, there we go. Thank you so much, Melyssa. I think for a lot of people, especially young people diagnosed with stomach cancer, one of the big questions is, why me? And I think genetics has a big role in answering that question. So thank you very much for shedding light on that. The next person I would like to introduce is Dr. Howard Lim. He is a medical oncologist at the BC Cancer Agency in Vancouver. He's also the clinical associate professor at the Faculty of Medicine at UBC, chair of the GI Tumor Group and residency training director. So we actually heard about Dr. Lim from one of our patients and members of our support groups, Mallory. And then we just kept hearing about him because he's just been all over the news because he's doing something really, really interesting. It's called personalized oncogenomics, and he'll tell you all about that. It's kind of the hot topic in cancer research, and we're just really, really happy to have him. He's actually only flown in from Vancouver, and he's catching our red eyes, so we're really, really grateful to have him here. So without further ado, Dr. Lim, thank you very much.
Thank you very much. It's a great honor to be asked to speak here in Toronto. Patient forums are amazing. I've spoken at many, and I feel they're really important because it just helps people feel that they're not alone, and it shows that we as a community are all together, both from patients and from a physician side, so it's a great honor. And I'm just finding my slides. So I do apologize for my voice because my 6-year-old son, who I love dearly, is a petri dish. So if I sound like a 13-year-old, I apologize if my voice cracks. And I use a Mac, so this is where I'm like, just show up. Oh, here it is. Okay. So I'm here to talk about genomics and oncology, and specifically what we're doing here in Vancouver is a program called Personalized Oncogenomics. But I'll take a step back and sort of go through some biology and technology. Here we go. So here are my disclosures. I have received various honorariums from pharmaceutical companies, and Lilly in particular, who has sponsored this, has sponsored me in the past for some gastric cancer research. It is important to highlight, actually, Lilly as a company has actually funded a large number of GI medical oncologists to get together. So there's actually a Canadian working group of medical oncologists that work with Lilly to help advance gastric cancer research. Despite these honorariums, I still can't afford a house in Vancouver, but. So how we normally kind of do cancer now is we look at some imaging and we take some cancer out of your body, either a biopsy or you have your surgical specimen, and we look at it under a microscope, and we do some stains, and we're really looking at kind of more of a top-down view of the structure of these cells and say, well, this is what we think you have. We think you have either a diffuse subtype gastric cancer or intestinal subtype gastric cancer. But we really don't have an idea of what's going on inside the cell. So we're kind of just making some assumptions of what's going on. And if you go back into your biology days, there's a huge roadmap that goes into what actually builds a cell. And as you heard from the last talk, cancer is actually a disorder of really the roadmap or the blueprint of the cancer cell. And what we're learning is that there are different mutations and different changes in the blueprints. So not all diffuse subtype gastric cancers are the same. Not all intestinal subtype gastric cancers are the same. And we're actually finding things are different than what we really realize. And what we're realizing is that instead of 2 types of gastric cancer, there's now these molecular subtypes. So we're not alone in this. So pancreas cancer, esophageal, colon, there are all these new molecular subtypes. I think pancreas, there's 4 molecular subtypes. And because we have these new molecular subtypes, and because we've also started to develop these newer targeted agents, these are now neuropredictive or prognostic factors. So about probably 5 years ago, HER2 was really a big thing in terms of gastric cancer. And then we started using Herceptin for gastric cancer, and patients have been living longer. We have MMR, as you've heard. So mismatch repair enzyme deficiencies might predict now who will respond to immunotherapy. do different expression profiles. And this is driving new clinical trial designs and therapies. So I also sit on the National Cancer Institute Clinical Trial Design Committee, and we've totally ripped apart on how we're doing clinical trials now. There's now a trial being designed looking at 10 different mutations and sort of taking gastric cancer patients and putting them into different arms of targeted agents based on their molecular profiling. And you've seen this now probably in every single talk, but this is really important, right? Is that we can now probably change how we treat gastric cancer. We're no longer going to say, you have gastric cancer. You might say you have an EBV positive gastric cancer and you might respond to a certain drug, or this is an MMR deficient or MSI high cancer. And so all of this is starting to drive how we change the way we treat people. So we're able to personalize therapy. And we already do this to a certain extent in some cancers. So this is using lung cancer as an example. We just used to say, oh, you have lung cancer, we'll give you platinum-based therapies. But as we learn more about the biology of cancer, we now know that if you're EGFR positive or you have an ALK fusion, you now will respond to different types of drugs. So crizotinib is now used for ALK fusion positive cancers. We use EGFR inhibitors for EGFR positive cancers. So we're now seeing, instead of this big lump of cancers, we're actually subclassifying these people into how they're going to respond to treatment. And we can also find out who's going to respond or not respond to certain treatments. So we can spare people toxicities from some of the therapies that we give. And that's really important too in terms of maintaining someone's quality of life. So, is this really a predictive marker? Hopefully, yes. Genomics has changed how we understand tumor biology. So we're understanding the cancer better, but sometimes we don't know if by understanding the roadmap, are we really choosing the right drug? So far, in terms of personalized treatment, the data we have is still experimental. And that's why we're putting it through all these clinical trials to really determine which marker will tell us whether you will or will not respond in terms of treatment. And there's many different levels of what we call genomic testing. So when I first entered the scene about 5, 6 years ago, and I was being introduced to the Genome Science Center, so we have this huge team at the Cancer Agency. For the most part, we do what's called panels, and this is what we do on the clinical level, and also on the hereditary clinic side, you just heard they do a genetic panel. So it's a simple screen looking for the presence of known cancer genes. It's pretty fast and inexpensive. And then you kind of move up the level of this, what we call exome sequencing. And what we do in Vancouver is what we call whole genome sequencing, and we do RNA expression. And in some cases, we even do, as a research project, what we call circulating tumor DNA. So taking extra blood samples and seeing, can we see tumor DNA in sequence and seeing targets? And I have a picture that will explain all of this. So this picture is complicated, but it's really to demonstrate how complex the information you can get. So most panel stuff is really here on the far right. We're really looking at discrete mutations, and you can see it's information you know. But as we go along to what we call whole genome sequencing, the whole genome is the entire map or the entire encyclopedia of your DNA. So my patients know I like speaking in terms of analogies. So a panel really is like a movie trailer, 2-minute snippet of the big movie, 2 hours. And sometimes the trailer is enough. I'm sure we've seen a trailer and then gone to the movie theater, sat through a 2.5-hour movie and go, all I needed was to watch that trailer. And sometimes that's all we need. But sometimes you watch the trailer and then you watch the movie and it's completely different. And sometimes the trailer does not represent actually what's going on with the entire movie. And sometimes you don't have to watch the entire movie. There's actually probably better snippets that they could have taken out to make the trailer. But that's what we're trying to figure out by doing whole genome sequencing, is we want to look and watch the entire movie and then figure out what snippets that are probably more relevant to certain types of cancers. But what we're finding is as we do whole genome sequencing, not all cancers are the same. Just like if you were to take a genre of movies like horror films and watch all the horror films, some are kind of funny, some are truly scary, and so now we're actually subtyping all of these different types of cancers differently. And we're changing how we treat patients, and sometimes we change the diagnosis. We're finding out what we thought was their original diagnosis is something completely different. So what we're looking at is different alterations in cancers, and this is talking about all the different variants, but it's not just mutations. Mutations cause different things. Sometimes your cancers will cause translocations, so parts of the chromosome will fix to other parts. You'll get amplification, so parts of the DNA will actually be amplified versus deleted. And some of these mutations, or what we call the quality of the mutation, is different. So sometimes if you just have a discrete mutation in a protein, it maybe only makes a small change in the protein. But if you have a deletion, then sometimes those proteins are vastly different than what the original protein should have been. And so the quality of that mutation is very different because how it's expressed is also very different. So there's lots of things that go beyond just sequencing, which is why we also try and look at the downstream effect. So your DNA is responsible for creating all the proteins, which is the building blocks of the cell. So if the blueprint is in error, sometimes your body can still compensate, but sometimes the errors that are made are just horrific, right? So we call this our personalized oncogenomics program here at the Cancer Agency. It is a clinical trial, so there's an informed consent process. Patients have to see one of us and go through a consultation. We then need a fresh tissue biopsy, and it's actually almost 4 core biopsies of the tumor. And then we sequence the cancer. Now, sequencing technology has come a long way. It took 10 years to sequence the first genome. We can do it in 24 hours now. Then we sort of have all this data generation, and this takes almost 2 to 3 months because you're looking at 6 billion bits of data. And then every single patient is discussed in a tumor board, and I'll have a photo of that. And then we have a discussion with the patient about what kind of clinical action should be taken, whether or not they should be treated with which drug, or should they go into a clinical trial, and we go from there. So this is an example, this is a breast cancer case of sort of the information we get. So every Thursday from 2 to 3, we sit down, and it's actually almost a lecture theater like this. There's about 40 to 50 of us. And we try and interpret this. So thankfully, there are smarter people than me, because I'm not that bright, I'm just a simple clinician. But we have to interpret this. And here, this patient with breast cancer has a hypermutated cancer. Maybe they'll respond to immunotherapy. They have overexpression of FGFR4, so maybe we should put them in an FGFR phase 1 clinical trial. There looks to be dysregulation of the cell cycle, so maybe we should use a CDK inhibitor or palbociclib. So this cancer has many options, but we don't know, even though we have this great roadmap, and it's pointing us in a direction, we don't know if those therapies really are going to work. So how I explain how POG works is, as a medical oncologist, outside of POG, I have a kitchen cupboard of drugs. For most part, that's kind of limited in terms of what we believe works for gastric cancer. And I kind of do this and grab the drugs and give it to the patient. And then we just keep going until we exhaust the cupboard. But if we have this information now, my cupboard's bigger, but now I kind of more have a dimly lit candle going through the cupboard to help me choose things a little better. So now we're going to choose things outside the box sometimes for some patients. So what this is really what happens when my son sends me a whole bunch of text messages. It's pretty much all these emojis, and really he's just trying to say, I love you. It's pretty much the same as genomics. You have all this information, and we come down to maybe 2 or 3 drug choices. So this is what we need all the bioinformaticians and all of us to come down and figure out what's going on. So this is our tumor board. We have medical oncologists, there's genome analysts, informatics, there's radiologists, we have our sequencing team, pathologists, project managers, there's genome science lab leader, and really important to this is also the hereditary cancer team. Because we're looking at DNA, it is really important to have a hereditary cancer team part of our project, because we actually pick up more genetic conditions, just like was explained before. You may have a young patient, and also on the standard panel, we're not finding out why this patient developed cancers. Sometimes we're actually figuring out why certain people are developing cancers that aren't on our standard panels. So this was my patient. It's a colon cancer patient. She's been the one in the news, but she had colon cancer, underwent her chemotherapy, and unfortunately relapsed, and then relapsed in the spine, had radiation twice, kept growing, was pushing on her spinal cord. She was almost bedbound, and she got a palliative resection, and we sent that off for POG. And so this was in the early days of POG where, in all honesty, we didn't know what we're doing. We kind of know what we're doing a bit better now, but not much better, I'll be honest. And on the expression panel, it showed this overexpression of FOS in June. So normal levels are here like 18, 22. And this woman had like 500 for FOS and 380 for June. So we're like, oh, what's going on here? And the analyst said, well, this pathway seems to be overregulated. You could try blood pressure medication. I'm like, are you kidding me? Really? and so she did not want to take any further chemotherapy because it just didn't work for her. And so I talked to her about taking this blood pressure medication, and I said, we'll do a PET scan and we'll see after a month. But I pre-booked chemotherapy. I'm like, this isn't going to work. Thankfully, it was only 50 cents a day. So from a financial toxicity perspective, we're not talking something super expensive. So this is her pre-treatment PET scan back in November 2014. And you can see she still had some residual disease in the spine. And she had lymph node disease all throughout the pelvis. And after 4 weeks, she had complete resolution of the disease on the PET scan. So I admit I was completely flabbergasted and was like, I'm not too sure what to make of this. She's continued on this medication actually now for 3 years, when she should have probably passed away about 3 years ago. So we've managed to find something unique, an alternative treatment for her. She's unfortunately now relapsed, but that was 3 years that we got her, that I didn't have an option before. So I admit, this one's a really outside the box case, but this gentleman was what we thought was a head and neck cancer, and so squamous cell cancer, and received all different chemotherapies and radiation, and unfortunately recurred. We gave him more chemo, and he was young, so we said, okay, and he's one of our early patients as well, and we biopsied this. And what we found was actually a mutation in what we call in SMARCB1. And this was actually diagnostic of a pediatric sarcoma, or an atypical teratoid rhabdoid tumor. And the median age is 9 months. This guy's 32. So, and the rest of it, what we could find was completely normal in him. So what we decided to do was we gave him sarcoma-type chemotherapy instead. So here's a PET scan showing he had a mass just off to the side of his heart. And after 1.5 cycles of chemotherapy, we finally get a response in his treatment. So we changed the diagnosis in this person. Now granted, it'd be incredibly hard to figure out a pediatric sarcoma in a 32-year-old male, but this is how genomics is changing how we diagnose people too. So this case is more of a 43-year-old woman with non-small cell lung cancer, and we found this unique fusion called NRG1. And so this was highly expressed, and there was a drug that blocks it called afatinib. So this is the CT scan on the left. This is her lung mass, and she's got liver lesions. And 8 weeks on her treatment, we can see that her disease has significantly shrunk. So it's like, oh, this is great. We found a marker for this drug. So now we're going to not treat within subtypes. Can we treat based on molecular testing? So this is a gallbladder or bile duct type cancer, cholangiocarcinoma. So this patient was 34. We sequenced her. And she also had this NRG fusion that's very similar to the lung cancer patient. So we said, well, if it worked in lung cancer, same fusion, let's try the drug. So gave this patient afatinib as well. And here's this patient's pre-treatment scan. You can see throughout the liver, lots of disease. These are all the shadows. And after 2 cycles of treatment, we can see regression of her disease. So this is we're no longer treating someone like a lung cancer and a gallbladder or bile duct cancer. We're saying you have an NRG fusion. Doesn't matter what your cancer is, we're going to try you with this drug because that is a marker of therapy. So we're kind of changing how we think about treating cancer now. But there's still many issues in terms of this technology, so this is still experimental. So sometimes we do this, and it gives us this great blueprint, but we actually don't have a target. So we increased our knowledge, but unfortunately it didn't help the patient themselves. It still goes into a huge knowledge base. So every patient, although it doesn't help them, it does help other people. And sometimes tumors are really heterogeneous, looking at lots and lots of cancer cells. So sometimes we're not sure if we're biopsying the right sample, because there is studies that show that sometimes what's going on in your liver in terms of the cancer there is different from what's going on in the lung. And sometimes we're worried about when we go through people's DNA, what else are we going to find? Now, we only look at cancer-specific things, but you certainly could go through the DNA and find out, well, you got Alzheimer's or something else. The other big issue is, can we access all these drugs? Not every drug is funded, not every drug is approved yet, so finding access through clinical trials can be difficult as well. The ultimate thing is this going to change our patients' outcomes? And in some cases, we haven't. In some cases, we've tried the blood pressure medication on different patients and it didn't work. So we're still trying to figure out how to incorporate this technology. But hopefully we're going to be able to use this personalized results. The NRG fusion might be able to be something that can be released to a population of patients who have an NRG fusion across tumor types. So for us, we have POG, and it funnels our patients into clinical trials, but it's also a huge area of collaborative research. So we get to interact with the scientists. So it's truly science going right into a patient, which is what we want. It's real-time cycling of the data right into the patient, from research, right, helping us choose better treatments for patients. So in Canada, there will be a move actually to do what we call a basket trial. What we're going to do is, and there's a few centers in the country that can do this. So we can do it in BC called POG. In Ontario, it's called Octane. It's a little different than what we do in BC, but it is a molecular profiling. And in Quebec, they're calling it Exactis. Profile is the pediatric arm of this trial. But what we're going to do is molecularly profile patients across the country, any cancer type, advanced cancers, and based on the mutations, they will get matched to drugs based on those mutations, so not your tumor type. So we're hoping to open this up next year. So I think there's 10 arms to this study right now. And so it's really exciting to be part of this. Actually, my colleague Dan is the overall chair of the trial design. So I get to work with a lot of smart people, because again, I'm not that bright. I just kind of throw drugs at people. So, and so this is really the design, is we do this molecular phenotyping, and then people are kind of put into these baskets of drugs based on their molecular phenotype, and then we're going to see if by doing the molecular phenotype, we can predict actually how people are going to respond to a drug. And this is actually happening in time for patients now. So the FDA has approved immunotherapy for what we call specific genetic feature or mismatch repair enzyme deficiency, or MSI-high cancers. So normally how a drug is approved is you have stomach cancer, and we're going to approve Herceptin for stomach cancer, and then we're going to approve it for breast cancer. This is the first time we've done what's called tumor agnostic. So it doesn't matter what kind of cancer you have. If you have a MSI-high tumor, you are now eligible in the United States to get immunotherapy. And it depends, now it does depend on which line of therapy, depending on what type of cancers you have, but immunotherapy seems to work really well in mismatch repair enzyme deficient cancers, and specifically probably Lynch syndrome is one of these hereditary conditions that will respond to immunotherapy. And this is just an example of the demonstration of the differences. So if you have a mismatch repair enzyme deficient cancer, these blue lines, and these are patients who received immunotherapy, you can see a regression in the tumor side. If it's intact and you get immunotherapy, here are the red lines. Cancer continues to grow. Keep in mind, immunotherapy currently is about $10,000 a month, so we don't really want to be spending $10,000 a month and exposing people to toxicity if it's going to grow. So now we actually have a marker that's going to tell us who's going to respond. So in summary, this is becoming really complex, lots of mutations, expression panels, proteomics, and there's many unknowns about how predictive the technology is, but it's giving us a better understanding of cancer in general. And our hope is that by profiling more patients, we can now figure out better mutation panels and figure out who's going to respond to what therapies. It also helps us understand the hereditary side. So I actually sit on the hereditary oversight committee, and we go through every single patient in terms of their risk of cancer and their mutations. So right now, the program does help kind of the individual patient, but as you can see, as we help more people and we see patterns emerge, hopefully we can apply that to a broader population. And that's how we're going to be successful. This has to be better than us just helping one person. It's about helping multiple people by understanding cancer better. So really the POG team is really Mark O'Mara and Janessa Laskin are the real big leaders in this. Actually, I'm a very small cog in a very big machinery. But it's a great pleasure to be part of this team. And if you have any questions, please ask away. Yes.
And you're seeing all the different mutations that the individuals may have. Can you potentially use this information to mitigate any adverse drug interactions with that person? I guess this is more of a pharmacogenomics kind of question.
So you're right. So part of the other part is we can now sequence and do what we call pharmacogenomics and determine are there mutations where people have toxicities from drugs. So a prime example is 5-FU or capecitabine, which is used commonly in gastric cancer. There are mutations, what we call DPD, or I can never, dehydrogenase, something. But if you have a mutation in that protein, you can't metabolize 5-FU, and some of the levels of 5-FU go up to almost 1,000-fold. So actually, one of my patients in Pagua actually came up with a DPD deficiency, and actually, so now I know not to treat her with 5-FU. There's other mutations for renotecan, which is also sometimes used in stomach cancer. UGT1A1 has been picked up in some of our patients. So we are seeing known mutations that will also help us with toxicity. One of our pharmacists did do a project with us looking at more experimental, like going through our panels and seeing if we can figure out, and she actually went through some of the charts of toxicities to see newer mutations about predicting toxicities as well. So we do have that as an arm of POG about pharmacogenomics. The thing about this program, it's a beast, right? You get all this information, you can do multiple projects, so it is amazing.
Thank you.
Don't worry, I'm on a panel, so you guys can grill me later.
Thank you so much, Dr. Lim. So we're going to take a 15-minute break, bio break, have a coffee. There's some snacks out there. You can ask some of the speakers questions, and then we'll be back and continue the program.